TopMedTalk.
Hello and welcome to TopMedTalk. I'm your host, Desiree Chappell, and we are at the IARS, the International Anesthesia Research Society, the AUA, the Association of University Anesthesiologists, and SOCCA, the Society of Critical Care Anesthesiologists. Now, I'm joined by my co-host, Mike Grocott from the UK. Hi, Mike. How are you?
I'm very good. Very good. Looking forward to this chat we've got coming up.
Yeah, we've had a little bit of opportunity to chit chat here on TopMedTalk the last couple of days. It's been a great meeting so far. Yeah,
We have really enjoyed it. As we said yesterday, really just getting back face to face, whole load of familiar faces, a lot of people to catch up with. It's been a great meeting, and it has that joy of being relatively intimate in comparison with some of the really huge meetings. So yeah. Great couple of days.
Yeah. Well, we're so lucky, Mike. We were kind of on our own yesterday.
It's executive summary.
I'm trying to say that in a really nice way. We're so happy to have you here, Monty.
It's great to be here. I'm just a bit distracted at the moment because we're in the coffee break.
Yeah.
And I'm seeing hundreds of familiar faces. It's like sort of the glitterati of academic anesthesia.
I know. I feel like the gang is all back together here. Yeah. Like we're seeing friends that we haven't seen in a really long time. And it really is like the leaders in anesthesia, critical care, perioperative medicine. Very cool. Monty, we were talking about this earlier, but just for our listeners, we're here at the annual meeting of these three major organizations with really kind of global organizations. Can you tell us a little bit more about them?
So it's three, and they're going to the abbreviations of AUA, SOCCA, SOCCA, and IARS. And IARS, the International Anesthesia Research Society, I think it's been around the longest. It is what it says on the can. It's a sort of global society for anesthesia research, although to be fair, dominated and led very much from the USA. And then just before that and wrapped around that is the AUA, which Mike will give us an update on in a second, which we're both lucky enough to be members of, and SOCCA, which is the critical care anesthesiologists, as opposed to physician surgeon, critical care docs. So anesthesiologists in critical care. Mike, the AUA.
Yeah, well, it's a similar mission to the IARS. Again, fairly US based, but with a reasonable international membership. So it's predominantly senior leaders, but also a lot of up and coming researchers in anesthesia based in academic centers.
So the U in it is the university bit, isn't it?
Absolutely.
So in the USA, I think we might define that by the residency programs, perhaps, of which I think, although there are thousands of hospitals in the USA, I think you get down to hundreds of residency programs. Is that right, Wael? So we have
that is correct. Yes, Wael Saasouh. I'm an anesthesiologist out of Michigan, and I'm the director for research for NorthStar Anesthesia. Yes, with the AUA, the academic portion is mostly the academic aspects of our profession, which seems to be concentrated a lot more in residency programs. Although we are seeing some more interest on the global side of things, and that's definitely something we're trying to work more towards, to involve more anesthesiologists in the academic pursuit in anesthesia, not necessarily just the university-based ones.
Yeah, so non-academic providers that are coming out of private practices, correct, things like that. Yeah, that's something. So Wael and I work together at NorthStar, driving research there within our organization, and it really is quite unique, right, Wael, to be able to do what you're doing as director of research in a non-academic organization. You are affiliated with Wayne State and some other academic universities, correct?
It is quite unique, and it's a fun challenge, and it's a very rewarding experience, I would hope, eventually, because there is the interest to pursue academics, but not everybody has the means or the how-to do it.
Yeah.
And coming from an organization which is focusing more and more on academic output, even though they are mostly based on non-academic centers, it's interesting to see the dynamics and how you can step in and help and drive better quality for patients eventually, which is our ultimate purpose, through academics and through everything that we're doing, all the projects, and which is why the IARS annual conference is one of my favorites, because it combines all the forward-thinking clinicians, whether they're academic or not.
Yeah.
And it's interesting to meet people, to network, to see what everybody's doing, and to see how you can apply all of that knowledge to places where it's not routinely done.
Yeah.
And we talked about this a little bit yesterday. I find your role fascinating as a director of research within a commercial organization. And the drivers for that, which I think are actually probably very similar to the drivers for, say, a hospital within the NHS. So what, if we could just rehearse that, why the NorthStar, where's the value of adding research to the NorthStar portfolio?
My position comes under the Office of Clinical Quality. And one of the ultimate goals is that we're trying to drive better outcomes for patients across the board, because the NorthStar footprint spans multiple kinds of centers, ambulatory surgery centers, hospitals, some clinics. So in order to drive proper progress in terms of quality, you need to do evidence-based approaches. And to do that, you have to study what you have, which may not be the same as what the major academic centers have, because they do their studies, they come up with their guidelines, which are excellent, but they may not always apply to rural areas or to ambulatory surgical centers, which don't have the same capabilities as those major academic centers or the expertise of the people on the ground. So coming in, looking at all this data, trying to collaborate with everybody at individual sites, you can do a more personalized quality improvement project per site. And then eventually what works at this place will work at another place. And we'll try to copy it forward. And for an organization such as NorthStar, which is, as you said, largely commercial, it's interesting that there is that interest to pursue these academics, and I'm lucky to be in the position.
So let's dive into an example of that to give that, to be able to get a grip on that. We'll come back later on today in some follow-up interviews, because you're in the main auditorium session later on with some colleagues we've referred to, talking about some big data examples of where real-world evidence from your centers have demonstrated a lot of hypotension.
Right.
Okay, which is, we've heard a lot about now, and we'll come back to it. And it's amazing that you've done that work, and it's great that you've got abstracts out of it, podium presentations here, and papers under review, possibly in press.
Right.
Park that for a second, and let's jump ahead to that's great. You've reinforced what we've heard from the ivory towers. You found the same signal in the real world, as we call it.
Mm-hmm.
But now what about do something about it? Desiree, you've started that journey. You've started to see if you can fix the hypotension, but not just the hypotension, the real issue, which is the hypoperfusion.
Yeah, we have. So Monty, I wanted to back it up for just a little bit and just touch on what Wael was talking about. So NorthStar, for a little context for those that are listening, is an organization of over 200 facilities across the U.S. In disparate locations, and we have over 3,000 providers. So you can see that we have a little mini NHS or at least the provider side. And so it's a huge task. Wael is taking this on to see how we can scale and reproduce the things that we're doing. An example of that is what you're referring to, Monty. We're working on in one of our facilities in Louisville, Kentucky, where I happen to do my clinical work, and I've been within the system for a very long time. And looking at, or realizing we still do have intraoperative hypotension. We've seen the numbers. It is a reality for us. I think when we saw that as a group, kind of said, well, there must be a way that we can avoid this and do better by our patients. We kind of thought we were doing the right thing, but maybe not. So what we are looking at from a quality improvement perspective is figuring out how we as clinicians can change practice, use different types of interventions, technology, not different algorithms, but refine the algorithms that we've been using to really make a difference and avoid hypotension altogether. At our institution, we do very large, multi-level, complex spine. Some of the probably, one of the busiest spine centers within the U.S., Leatherman Spine Center. Steve Glassman is chair of that program, and we have been. It's been a really interesting collaboration with Leatherman and Norton Healthcare and NorthStar. And I think our clinicians are really excited. We have about 26 patients under our belt now, and looking forward to see, what we can do to improve care.
So, and we'll loop back that in a moment. I'll come back to you, Wael, about the design, and then I'll come back to Mike about the concept of registry nested trials and efficiently answering these questions. Desiree, I think you've specifically been looking at hypotension prediction index, which has attracted a little bit of attention in various different editorials and commentaries recently. where the academics want to have opinions.
Yeah.
As one of our colleagues in South Africa used to say, largely uncontaminated by data. You say, but you've been having some real world experience.
We have, yeah. So we, full disclosure, working with Edwards Life Sciences, using their newer technology, the Hemisphere and Acumen Predictive Analytics, and HPI, the Hypotension Predictive Index. And, I will say that our group we have been using advanced hemodynamic monitoring for quite a while now, more than several years, probably 7 or 8 years, and transitioned to the new technology. And, it's so interesting because I will say that I always felt like I was doing a good job, really have a great handle on all the different hemodynamic parameters. But bringing in this new number, it took a little while to get used to figure out what it really meant to our patients, what it meant to me and the whole picture. But it's been enlightening, and just trying to figure out the different interventions that we do to avoid hypotension using vasopressors versus fluids versus inotropes, seeing how the hemodynamic parameters change, having confidence with the monitoring technology and those numbers, and really figuring out how do I use that to not necessarily predict hypotension that's happening, immediate within 5 minutes or within a couple minutes, which if we're waiting for some of those index numbers to alarm, but looking a little bit earlier than that, when we start to see some trends moving along, saying, wow, I see some trends happening. HPI is starting to go up. Can I start looking at what the possible causes of that may be? And can I actually avoid hypotension altogether?
Because some of the recent criticisms, Desiree, have been that because of where the alarm is set for HPI, when the alarm's allowed to go off, you can already kind of see that you're going over the edge.
Yeah.
Because it's set very late. It's a kind of you're about to crash alarm.
Yeah.
So at that stage, that if you just look in isolation at that, the HPI kind of mirrors the blood pressure.
It does.
And then if you treat, the blood pressure measures the HPI, which is kind of not the point.
Right.
It's the half an hour before that is the interesting bit. And are you seeing at lower levels of HPI changes happening in the hemodynamics?
We are, for sure. Monty, I always like to say it's kind of like my Volvo. When I'm in my Volvo and I'm not hitting the brakes when someone in front of me is braking, it's going to start alarming and hitting the brakes. But I have lane control and some of these things saying, there's traffic coming up, all these different things, notifications that things may be occurring here in the future. And so this is the same way. And I will say that, if we look at the index number, 85 is the alarm. Well, if you're seeing an HPI of 85, like you said, you're about ready to crash. Your mean is already dipping down into the 70s, lower 70s and upper 60s. But we're noticing that when we start to see an HPI of about 50, start really looking at, well, where are other numbers? What are our trends doing? What's what's stroke volume doing? What's cardiac index doing? Are those numbers drifting? Are we seeing a derangement? What's the blood loss? All of these different things we start seeing we start seeing changes there around 50 to 60. And then that's when we start saying, well, maybe I'm going to, treat those or give a little bit more fluid and make sure my index is fine. Is it a cardiac, we were seeing cardiac depression versus like fluid.
So you're not
issues.
just giving a vasopressor when the MAP gets to 70.
No, absolutely not. Yeah.
So I'll come back to you in a second, Desiree. So while, you're going to try and address this with an academic slant, so you've got IRB approval to do a form of a study. Can you expand on that?
The study is basically trying to utilize this technology to see if it makes any difference. So we have historical data from the Norton Center. We know our incidence of hypotension. We know what we've been seeing for the past couple of years, say. And this technology is very enticing. We know that if you predict it, you're probably going to treat it better, but we don't know that for sure. So we want to have some practical data that tells us, yes, if you use this in a certain way, are you able to follow the institutional guidelines a little bit better? Are you able to mitigate some of that hypotension that you can prevent compared to what we've been doing over the past couple of years? And the intent is the same. The intent is always to avoid hypotension because it's better for the patients. We now have a slightly different lens to look at it and to interfere probably at an earlier stage. And once we link that with outcomes, hopefully that also translates into better patient outcomes, less adverse events afterwards, and so on.
So when you get the earlier signal, the extra bits I think I'm hearing, and I think we all know this, but just for everyone else's sake, is when you look behind the thing that says you something is going on, it tells you about preload, afterload, and contractility.
Correct.
And then you choose one of those three therapies or two from three. You don't just keep giving phenylephrine.
Absolutely.
Yeah, okay.
Because if we rely on one of these methodologies, we tend to overtreat in one direction and ignore some of the other directions. And when you have all this data in front of you in a more clear and concise manner, you can individualize your treatments, which might even change for the same patient at different points during the surgery. So when you have all that information available to you, and it gives you a clearer indication of what the cause of the hypotension might be, or the upcoming hypotension might be, then you can treat it a little bit better, we would hope.
So in stage one, and I know a bit about this because I've been talking to you about it, I think the first thing you're doing is you're testing the feasibility of your algorithm and you're testing compliance with it.
Correct.
Mm-hmm.
Yeah.
So is that?
Yeah, no, that's correct. So we've had a Fedora protocol in place for years.
To expand on that a little bit, the Fedora.
Yeah, so it's a stroke volume protocol that integrates hypotension, and it dives into fluid bolusing and then looking at cardiac index and blood pressure. And then, sorry, I'm getting distracted with a lot going on in the room now. And so we've had that in place, and what we are really trying to look at is integrating some, the relief trial and just going ahead and giving our patients a fluid bolus up front, co-loading, and then looking at cardiac index. And then if we start to see hypotension, or that it may be the HPI may be predicting hypotension, then we look at doing another fluid bolus. And then lastly, we would be adding a vasopressor. So that's really at the bottom of the list now.
So just so we throw them into the show notes, the Fedora term relates to a study called Fedora.
Thank you. That's what you were getting at.
And we'll put that into the show notes, the link there.
The link.
And the algorithm there that looked very successful in terms of outcomes, multi-center, addressed preload first, so it gave fluid boluses to maximize stroke volume. Then it looked at cardiac index, so it addressed flow. And then and only then it addressed pressure.
Yeah.
So I think you're replicating that in achieving your goal. And you also mentioned relief.
Yes.
Which we'll put in the show notes again, which was being moderately liberal is better than being restrictive.
Right.
Okay, so using HPI and you're looking at compliance with that algorithm.
Yes.
Now, when you get compliance up, what's your ambition for compliance?
So you mean compliance with the providers?
With the providers. Because if we look at the literature recently, we've had examples where it's been 50%, for example, compliance. It's slightly worse than if you didn't ask for compliance, which is usually about 65%.
Yeah. I mean, we're aiming, so we've really pushed this with our clinicians on the ground to say, if you're going to be taking care of your patients and participating in this, we're asking that everybody really sticks very closely with the protocol. So I whether or not we get 100%, I don't know about 100%, but I think that we'll definitely, reach above 90%. I would hope so.
And anecdotally, because we've seen recent literature suggesting that almost everyone's getting phenylephrine now.
Yeah.
And things aren't getting better, they're getting worse.
Yeah.
Even though hypotension's getting less.
No.
Are you noticing other treatments that are being used any more often?
Anecdotally, I do feel our use of crystalloids has increased. Our volume has increased. As I've talked to providers, I think people thought they were giving plenty of fluid. I mean, we definitely swung the pendulum to a restrictive approach about 5 or 6 years ago, maybe 8 years ago. And so I think we've been slowly chipping at, it's okay to give some fluid in these prone spine patients. And so I think this has highlighted that even more, that they didn't realize they still were restricting fluids. So I think we've increased our fluids. I think we still have a little bit of reliance on vasopressors, but I think people are reaching back in for inotropes that we previously kind of stepped away from for a little while.
I know Mike's chomping at the bit to come in with a few things.
I know.
I'm going to tee up one last ball.
Okay.
And then we'll let him hit a row of them. Okay. So the last
one of asking questions, Monty.
He's making notes. So the last ball I'm teeing up is that you mentioned that the Leatherman Spine Institute is part of a national registry of outcomes.
They are.
So they know the outcomes on thousands of patients, and they have access to tens or hundreds of institutions.
Yes.
So your outcome measures, if you and when you progress this, are already available there. Is that correct?
They are, yes. That is something that Dr. Glassman was heavily involved in starting the National Spine Registry. And they have already been looking at different outcomes, surgical site infection, things like AKI and spinal cord monitoring, and a host of other things. One thing that we've talked to them about is looking more closely at stage 1 AKI. So that was something that they never really looked at before. Looking at other things that were given during the case that they hadn't looked at. So fluid totals and vasopressors.
So for the record, in the short term, in the feasibility, you're looking for high compliance.
Yeah.
Correct.
And some sort of signal, I believe, that one of those outcomes will be a bit better compared to. Which one are you going for as your main?
Mostly the acute kidney injury.
Yeah.
Okay.
Yep.
Yeah.
As a kind of
canary
in the
marker of how well we're adhering to this and whether it matters or not. Because it's one of the easier ones that are measured. We can look at cardiac markers as well. We can look at a few other things. But it seems to be one of the more obvious ones to go targets to go for. Yeah.
So, Mike, I know we've got a list of questions and comments there. And at the end of it, I want you to touch, if you would, on the concept of registry nested trials and studies. Save that one and ask your other questions first. But that would be my question for you at the end.
Well, I guess, really interesting to listen to you talk about this study. I guess the thing that is implicit that maybe we should make explicit, thinking over the number of years that we've been involved in different fluid studies, is this the U-shaped curve concept. Mm-hmm. So you can clearly do harm if you give too much fluid.
Right.
But we've also got an increasing amount of evidence that you can do harm by giving an inadequate amount of fluid. And that was, there's the so-called Bellamy curve from an editorial in the British Journal of Anesthesia back in about 2005. But there's a lot of data to support that now. So we've got big epidemiological data showing, if you like, a sweet spot of not too little and not too much fluid, looking at tens or even hundreds of thousands of patients. And then we got the relief study. So we touched upon it already, a randomized controlled trial comparing full-on restriction with something a little bit more liberal. And I think perhaps to the surprise of many, but entirely consistent with the Bellamy curve, the outcomes were better in the group that had a little bit more fluid. So not lavish amounts of fluid, but maybe a positive balance of 1 to 2 kilos, and as you've touched on with your
primary therefore outcome, 1 to 2 liters.
Yeah.
1 to 2 liters, and the kidneys were definitely a bit happier, and I think that was a big turning point for a lot of people who otherwise were going to I must give less and less from an enhanced recovery perspective.
There still seems to be it's very hard to generalize for countries, but I haven't been anywhere or talked to anyone here recently who isn't restricting.
Yeah, it's still ubiquitous.
I mean, by here being the United States of America. It's a very, very big continent to generalize like that, but it seems to be extremely common and being reported in multi-center studies in the literature now as well.
And fascinating that the enhanced recovery literature, which predominantly came from Scandinavia at the very beginning, and they didn't say restriction.
They never said no.
It was avoidance of fluid overload as opposed to restriction. But, language has huge impact. And that word restriction, I think, has potentially caused quite a lot of harm.
One interesting aspect of this is that this approach to restricting fluids is not only sticking to anesthesia providers, it's bleeding over to surgical colleagues who read some of that, and then blanket statement, everybody gets 500 mLs of fluid for a robotic surgery, which is not personalized, and it's not it may not be appropriate for everybody. For some patients, yes, it would be appropriate because there are other considerations like bladder volume and all that, but it's a good time now to kind of enhance the message a little bit, to tell people how you should approach this topic, not just everybody gets less fluids or everybody gets more pressors.
And the phenylephrine infusion seems to be becoming almost normal.
Right.
Well, if you think about it, when we went with IARS and that term fluid restriction, which, by the way, plug for TopMedTalk, talking to Brigitte Brandstrup last summer about the term fluid restriction. We went through the whole thing. She wishes she never branded it like that, or that terminology ever came out. But with the IARS protocols, if we fluid restrict and we can't give any fluid, we want to avoid IOH because that's what the literature is saying. IOH is bad.
Now you set your alarm at 70, allegedly, is the secret source.
Right. And what else do you do? All you have are vasopressors at that point. So, I mean, we've really limited and kind of painted ourselves into a corner with our ability to treat hypotension and actually manage hemodynamics instead of just treating a blood pressure.
UK anecdote, Mike, which we've shared before, when our enhanced recovery program about 2010, when we were in sort of peak early rollout, we started to see the same signal, didn't we?
We did it, and in very low risk patients. I mean, we particularly, one of my colleagues in Southampton flagged up the fact that he'd been an intensive care consultant for longer than he probably cared to mention, and all of a sudden, I mean, not hundreds, but we were starting to see patients for routine joint replacements who were coming in with an acute kidney injury, and a handful of those were requiring renal replacement therapy, and that was a new observation for us, and that seemed to derive from this notion of fluid restriction. I must not give fluid, and that the kidneys became very unhappy.
So we had to write national guidelines and consensus statements written by anesthesia and surgeons to say, stop already, because we have national data, so we could see at a national level the post-operative AKI rates had gone way up.
Yeah.
So it's a shame we have to relearn all these things.
Well, and I think part of the problem, we are relearning, or we're not learning from our colleagues globally. But I think part of the problem too is that there is, with surgeons, they are dictating a lot of what's happening. We're not having great conversations about, okay, I'm fine to fluid restrict that, but do you know how much how much I'm having to support this person's blood pressure? And then we don't have great communication about what happens post-operatively. And I know we've talked about that here, and this is one thing that I try and spread the message a lot about, is that in anesthesia, we are not able to see our patients post-operatively anymore. And many groups don't have folks working in critical care anymore. We're doing just anesthesia. And so there's no communication. There's not great communication. We're not looking at our outcomes all the time. We don't have access to our outcomes all the time. So we don't even know that there's a problem that exists.
Desiree, just for clarification, you don't mean the doors are locked, do you? You mean that there's no allocation of time?
Yes. Yeah.
And resource to be able to see that. But you work very closely with your spine surgeons. I've been privileged to visit a couple of times.
We do.
Very impressive spine institute, one of the biggest in the United States of America.
We do.
Very engaged surgeons who are academically very successful and capable. Yeah. And you do seem to work together as a team there.
We do. We've had great communication. We started off, actually, some of our earliest collaboration was doing opioid-free and opioid-sparing spine, multi-level complex spine. And then, whenever I arrived down there, started kind of beating the drum about hypotension and, outcomes and things like that. And so really got interested in the hypotension piece with the group. And so they just kind of took it and ran with it. And we are, very lucky to be collaborating. Wael is helping to lead that project.
And in the opioid sparing example, you showed differences in outcomes.
We did. Yeah.
And you lent on the registry to do that. And that then was spread with other centers who lent on the registry to do that. So, Mike, in closing, back to the power of registry nested trials.
So this goes back to the internal external validity story. You want to discover something. Does this new drug work? You do a small, tightly controlled experiment, high internal validity. You work out the drug works. Will it actually work in practice? Is all about generalizability. And unfortunately, a lot of our big randomized control trials are arguably not very generalizable, because we are quite restricted in the way we have all these exclusion criteria, and we can only recruit particular types of patients.
And we tend to go to places that have residency programs.
And we go to places that are established.
So we go to a tiny, selected, arguably non-representative place where the minority. I come from one of those places. I'm not being offensive here to those places, but the vast majority of surgery takes place elsewhere.
And so in contrast to that, we've got this notion of platform trials, which are, number one, cheap, and some of the big effectiveness trials have become hugely expensive to the point that it's hard to be sure that there is value from the
They're not cheap, Mike. They're great value for money.
They cost less. But they have a number of other virtues, because the aim is to recruit as many patients as possible. So there are notions such as point-of-care randomization. So when you come to give, for example, you just click analgesic, and the medical record, the electronic medical record, will say paracetamol or Nurofen, if you wanted to compare those two, for example. And so somebody would have to deliberately opt out to not do that. And theoretically, you could recruit all patients of a particular category across a number of centers if you've got a health system. And that should be a much more generalizable result. It should have a lot more face validity. People will believe that because it relates to their own practice and it's less expensive.
Wael, what do you, we've had this conversation a lot. Where do you think, we can fit in as NorthStar, and some of these larger non-academic, programs can really lean into this?
I think one very interesting aspect of what we're doing at Norton is what Monty was just talking about, the collaboration between the anesthesiologists and the surgeons. When you have a cohesive group that has similar goals and they both are focusing on the same thing in places where there's a lot of overlap in responsibility, it really drives better science. And you don't need to be an academic center to do that kind of science, as long as you have all the people involved in the process be involved in the quality improvement. So I think that is one of the unique perspectives of what we're trying to do. And I think if we can figure out everything that works there and try to emulate the same thing at other places, before you know it, you have a global or a national level initiative that would help patients, which is ultimately our goal.
Yeah.
That is a little more practical than the way we do things right now. So I think that's one of the major goals that we have after we finish phase 1 and phase 2 and phase 3 of these projects that we're doing now. So we're trying to expand from local to national, and hopefully we'll learn more along the way, and then everybody else can benefit from what we're trying to do.
Yeah. And then Mike and Monty, you guys have been doing this for longer than we have.
Yes.
Just saying. What do you think of the feasibility of doing this? Do you think we're kind of going down the right track?
I think it's a great idea. I think for answering these clinically relevant questions, for the implementation questions, these types of approaches, be it platform trials or straightforward before and after studies, but in large numbers of patients in the real world, so across a spectrum of different types of clinical setting, are really important.
So, and I think we learned so much during COVID the hard way. Many of the answers we got out of that was accepting, the sort of registry nested point of care randomization, variance in practice, capturing big data. We got some what we believe are important answers out of that quickly for things to do and things not to do.
Yeah.
Which we'd still be talking about some of those wacky therapies if we hadn't had the opportunity to deal with it during COVID-19. So I think we're on exactly the right path. Now, you'll find early on, we were discussing this earlier, is it's highly likely to begin with that you'll struggle to get published in the so-called big journals. Mm-hmm. Don't worry about them, if you see what I mean. They'll come round, would be my suggestion. There's still this belief that if it's not a prospective randomized controlled trial funded by a particular agency with particular people involved, we're just about to see the results of one of those. Myself and Mike have been involved with how many years now, Mike, to do a few thousand patients? It's not great work. But
the
Optimize 2.
The Optimize story goes back to about 2004-05 with the original study. And this study, I would guess, the beginning of the last decade, roughly, 11-12, we started thinking. So Rupert Pierce leading it.
Great study, fantastic, really important work, et cetera, et cetera. But, at the end of it, it's still going to have to go to the stage that you're talking about.
Yeah.
Right. Which is to test it in the real world. And if it works for your organization, it doesn't mean it worked for my organization. So we have to replicate that again and put it into real world practice. But thank you. Great for sharing.
Well, Monty, thank you for that. Gentlemen, Wael, thank you so much for taking the time to sit down.
It's a pleasure.
Yeah, absolutely. And talk about it on TopMedTalk. This is exactly what we love to do here, and get the message out about what we're doing and really learning here. So thank you so much for listening to TopMedTalk. You can always find us on your favorite podcatcher. We are on YouTube. You can catch our videos and podcasts there. And be sure to check us out on social media. We're on Twitter, LinkedIn, Facebook. We're on all of those, and we love to chat. So thanks for listening. We're going to be back with other content and other conversations from the IARS, the AUA, and the SOCCA annual meeting here in Denver. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.